So Ron, as someone who's got a huge oversight into the NHS, what do you think is the long-term future and the answers, possible answers to this dilemma that Peter's so eloquently defined?
I don't think there's a. Can you hear me? Is that working?
Try and get close there. Yeah.
Here you go. I don't think there's a single answer. I think Peter's, at the last minute, really rather well summed up the dilemmas we have. I think the one thing I would say is that I do believe there's going to be three elements to this. The first is clearly managing demand, and by that I mean looking at how much care we actually need to provide, and over a longer term, probably ensuring that the population takes more ownership of its own health and understands that their lifestyle decisions ultimately have an impact on their need for health care and therefore the need for the NHS expenditure. There's a second piece that Peter refers to about efficiency. There's no question that although some people, I think, exaggerate how possible this is, there is no question the NHS could do more with the resources it's got or any resources it will have in the future. And there is certainly differential efficiency across the system. But notwithstanding those things, I think it is very difficult for anyone in the healthcare system, for the reasons that Peter gave, to believe there will not be a continued need for growth in public expenditure in healthcare. It just depends how much that growth is, I think. And the argument I think I would give there is that to look at the spend, the GDP proportion of spent on health in the UK, which is at best average with our peer group of similarly wealthy countries. And if you include social care spend within that, as Peter said, that's a separate spend, then it is considerably less than that average. And one of the extraordinary things that strikes me often is that America, the United States, which of course is famous for having a hugely private healthcare system, actually spends, as a proportion of GDP, virtually as much as we do in public expenditure on healthcare through Medicare and Medicaid. So the notion that somehow the NHS expenditure is excessive, I think, just doesn't bear scrutiny. It's also true that the wealthier countries become, the higher proportion they tend to spend on health, which I guess is a sort of sophisticated Maslow's hierarchy of needs bit, that the more you've got your basic needs looked after, the more you are concerned about other things. So I think I would certainly, I would strongly believe there's a need for an increase in health spending over time, and probably more than the sorts of numbers that were quoted in the party conference. But we need to get back something for that if the taxpayer is going to consider that as appropriate. And I think there's three things that I would probably emphasise from that point of view. One is that I think quality is where we should be driving. I think too much of our, certainly from a hospital perspective, too much of what we do focuses on efficiency and cutting costs for its own sake, whereas I would prefer that we actually looked at the quality of care. I don't actually believe that quality and cost are in an inverse relationship. I actually think that you can actually save money by focusing on quality, and not just because obviously if you have to do things twice it costs because you got them wrong the first time, that it costs you more, but also because I believe there are ways in which you can streamline the service by focusing on how you can deliver it most effectively from the point of view of the patient. I think in doing that, it is really important that you involve the staff of the organisation, and I think one of the things which is essential is that clinicians and indeed non-clinicians working in hospitals often know what's best, often know what goes wrong, often know what are the issues, that if only they were improved things would be more effective. I give a small example from well, not such a small example actually, from my own trust. We have something called Fit for the Future, which is a programme that we use to try to bring together our quality and safety and performance and efficiency agendas. And we have 28 work streams inside that programme, each of which is headed by a board director and a senior clinician, and work through how we can improve efficiency and effectiveness and improve quality. And the consequence of that last year was that we actually had a successfully driven cost improvement programme that saved £70 million in 1 year in the trust. And at the same time, what were, to be fair, already high quality performance and safety metrics actually improved. So we had the best HSMR in the country last year, for instance, the mortality rate figure at the same time as that cost was coming down. And I think the principal reason that was happening is that clinicians were actively involved in driving those things through. The second thing I'd say is where I think Jonathan will probably go is that research and innovation has got to lead us to a future which understands that there are very different ways of going about the delivery of services using not just technology but other innovations. Genomics obviously comes to mind in that regard, and cell therapies and other opportunities which will be available going forward to actually better target what we do, better organise what we do, and try to prevent the need for people coming to a very expensive environment in a hospital when they could be just as well cared for or diagnosed in other environments. And we've got a big program at the moment which we call Tahiti, which I won't bore you with the detail of, but the principal basis of that is to try to focus on imaging as in the leading edge imaging as a way of ensuring that we have more effective pathways for patients and allowing them to have care in primary care that they currently have to come in secondary care, that allows them to be at the focus on the right sort of care at the earliest possible moment, and allows us to use very innovative research findings to drive through those improvements into healthcare systems locally as fast as they possibly can. So some of the lead time, which is 10, 15 years often, of good research getting into practice is cut very considerably. And the third thing I'd say, which Peter referred to, is that we need to integrate care. I'm not an advocate of yet another reorganisation. The NHS reorganises every 5 years. I once counted how many reorganisations I'd been part of in the NHS, and it was ridiculous. Literally 25, I think I got to. I don't think we need another reorganisation, but we certainly need the organisations that work within the NHS and social care working together much more effectively than they have in the past. The structure we have at the moment isn't built around patients at all. It is built around the needs of particular parts of the system. And I think if we reorganise ourselves, both on the commissioning side, so that we are commissioning for outcomes across health and social care, and on the provider side, so that primary care, secondary care, community services, and social care are working together in ways which actually create probably virtual organisations that can respond to that more effectively. I know different parties have different approaches to that. The Labour Party, Andy Burnham, has been quite keen on actually integrating formally the provider end of things, whereas the Tory party's got a rather different view, although it does, I think, support the notion of integrating care. And the fourth point I'd make, Matthew, which is probably the most important of all, is we need, in all that we do, to take the patients and public with us. They need partly to do with the way they deliver. They've got to be involved in the co-production of care so that they understand what's going on and they play their own part in their own care. They've got to be very influential in what care they receive. I think we need to plan the changes that I've just been talking about with the public, very actively involved. We have an integrated care board at the moment which has got effectively citizens' leadership of it. I think we need to involve them, and I think not only will that improve what we're getting, and it will not only focus better on what patients and public want, but it will actually allow them to understand better the very important need for radical change in healthcare. I mean, too often public, I think, feel that change is done to them and that somehow is a conspiracy. People are trying to close things to save money, when actually they're often trying to change a system to improve the system for patients. And if patients and public were more actively involved and more central in the process, then I think they would better understand why that change is necessary and feel not just relaxed about it happening, but supportive of it happening and encouraging of it happening.
Thank you, Son.